All right, let's have any questions. Yes?
This question is for Dr. Markowitz concerning the low-dose CT scans. I'm wondering what the medical and public health community needs to do to either have OSHA surveillance, the medical surveillance provisions updated so they don't just rely on x-rays, or are there things that some of the associations need to do to kind of put out policy statements? How do we kind of push that issue with respect to insurers?
Thank you for the question. OSHA passed a rule, should have become effective January 6th of 2017 on beryllium. And beryllium is a lightweight metal, which is a established human lung carcinogen. There are not all that many workers exposed to beryllium, but there are some. That rule that OSHA promulgated included low-dose CT scanning for those workers. It was the first time OSHA has ever put in low-dose CT into a rule. Now, OSHA regulates a whole bunch of lung carcinogens, such as asbestos, such as silica. That new rule did not include low-dose CT. The asbestos standard's been modified over the years, but no one's ever looked at, for asbestos workers, putting into the rule changes a coverage for low-dose CT. So this is definitely something that needs attention. And in response to the issue about how we achieve that, yes, the professional associations, the lay organizations, the advocacy organizations, we very much need help in making this happen.
If I could just add to that, I think that one of the difficulties with just having OSHA address this is that OSHA covers workers who are employed. For most people, the risk of getting mesothelioma, or of lung cancer for that matter, is after the people leave employment. And there is really no good provision that I'm aware of at the moment for the surveillance of the people who are really at risk, who are the people who left work. Of course, the same considerations, I think, go to the high-risk communities, the people in Libby and Ambler and elsewhere, and certainly putting it in OSHA, I have nothing against it, but it's not really going to get at the nux of the problem.
So if I could just add to that, that's true that the retired period is probably the period of highest risk, but if workers get introduced to this technique while they are workers, they will know when they retire to tell their physician they're exposed, and they will request that test in the future. So the inclusion in the standards for current workers has an effect for after they retire.
Other questions?
I have a question, if I could. If there. Okay.
Mm-hmm.
Doctor, when you have been diagnosed with asbestosis while you are working and would like to be tested every year as a precaution, you don't think that OSHA is responsible for doing this?
Well, OSHA has specific requirements in the standard for repeat testing, but the OSHA regulation does not include low-dose CT for lung cancer screening. It has never been updated to include that. So yes, there's a requirement for chest x-ray. There's a requirement for examination by a physician. But at this point, in terms of really intervening meaningfully, frankly, low-dose CT is going to be very important. But it's not required by OSHA.
Thank you.
Just to follow up on that, then it seems like if we were to take advantage of the low-dose CT scans and we were to find some of these early tumors and then did biopsies on them, we may be identifying asbestos-related lung cancer? Or, I mean, can you, when it's a tumor, a lung tumor, would the biopsy identify asbestos fibers in it?
Well, Dr. Flores can address this more specifically, but when it's detected early, it's not biopsied, it's removed. And you get rid of the cancer. And when it's detected at stage 1, it's usually the end of the story in terms of treatment, and the person leads a normal life. Now, yes, you can look at asbestos fibers in lung tissue or in tumor tissue, but the most important thing is identifying the risk by history of exposure to asbestos, making sure the person gets to that CT scan and has the chance for early detection, if that answers your question.
Yeah, and at the time of surgery, because when you look at the specimen, sometimes they don't check it for asbestos, et cetera, but at surgery, when you look at the lining of the chest wall, it's called the parietal pleura, you see asbestosis in there, so the surgeon can tell you. I think the important point is that when you're screening, exposure to asbestos probably doubles your risk when compared to that of smokers. So the risk of lung cancer is much, much higher in those who were exposed to asbestos, and that's not included in the screening process. So I think we have to reevaluate that, and we have to push for people who are exposed to asbestos to get screened, because their incidence of lung cancer is higher than smokers. Let's go ahead and load the next one. If there are any more questions, yes?
Carmen Lima from Portugal. We have numbers about mesotheliomas in Portugal, and we had a 2-year-old mesothelioma child. How it can be possible?
Yeah, I mean, those are the rare instances. The youngest I've taken care of has been a 9-year-old, and there's got to be some genetic component to it that predisposes them to this. I'm not aware of mother's exposure predisposing you to this, so I assume it's the rare genetic component, but Marie-Claude, maybe you can talk about that.
There is one gene known to be involved in several cancers, including mesothelioma, which is BAP1. There is many literature on the subject. But when we look at the percentage of patients exposed to asbestos, there is also a little percentage which is not exposed. So we cannot say 100%, I think, maybe 95, but we cannot exclude that there are some, especially when they are very young, that are not exposed. But BAP1 is one sensitivity factor for different mesothelioma, uveal melanoma, and other renal cancer also.
Last question.
Fernanda from Brazil. I would like to hear your opinion about our doctors in Brazil demands for all ARDs the high resolution CT, even for pleural plaques, to report to the diagnosis and the relation with asbestos. I would like to know if we need to expose all these people to high resolution CT for example, no malignant diseases. What's your opinion?
So I think if we're screening, we should stick with low-dose CT scans, even though I don't think there's a lot of evidence out there or any good data to tell us how much more at risk patients are from being exposed to CAT scans. I think they're relatively safe. And so I would stick with the low-dose CAT scans. Many of these pleural plaques are calcified. However, just like in Libby, Montana, you have this thin fibrotic pleural disease that is not calcified. So we are in the process of doing studies, and we have published some papers on this, headed by Brad Black, where you can use low-dose CT scan to identify these non-calcified pleural changes as a result of asbestos exposure.
a single high-resolution CT is okay, but it's not going to be useful on a repeated basis. It's too much radiation. It's 8 times the radiation of a low-dose CT. So an initial one is okay. It will give a better picture, but low-dose CT gives a really good picture both of the lungs and of much of the pleura. And that low dose is what's key to doing it on a repeated basis so that you can pick up lung cancer early over time.
Okay, very last question.
Is the low-dose CT scan beneficial for early diagnosis of mesothelioma?
I would say yes. We have identified mesothelioma patients with the low-dose scan. Because it's so rare, it's hard to quantify, but in the anecdotal cases that I have seen in people who are at risk who have gotten a low-dose scan, not necessarily because of the asbestos exposure, but because of the smoking exposure, and we have identified mesothelioma. It's rare, but I think it is useful. So let's end the question and answer period. I'm going to ask Dr. Richard Lemon to come up here to introduce our keynote speaker.